Okay, let's go to PVR because we are very late. Then let's remove some slides for the statistics.
Sure.
PVR. I'm going to say things that perhaps sounds to you very old. Okay? Look at this. PVR is the main complication of a retinal detachment, as you said. It accounts from 5 to 10%. This is written in the literature. 5 to 10% of total retinal detachments. And they say that you have more in giant retinal care is written in all books. I don't think so. In penetrating trauma is so clear. You have more PVR in penetrating trauma. Different degrees have been classified, trying to compare results, compare techniques. But this classification, they don't. You cannot use them, because you don't see how mature the membranes are, how stage there are other things very important in PVR. Hypotony, for example, is one of them. Persistence, existence of colloidal detachment. There are many things that are not in the classification. Then, this is a way to say, okay, PVR, gray PVR, okay? And then we have been talking about the posterior border of the vitreous base here. And this is very important that you understand what is the posterior vitreous. The posterior border of the vitreous base. Is this the posterior vitreous of the vitreous base? Is this the incomplete vitreous removal? Okay? And then you say, okay, complete vitreous removal. But why you didn't remove the vitreous? These are remnants that remain over the surface of the retina, that they are not that easy to be removed. And don't, now very unpolitical sentence. I don't believe that this, trimming of the vitreous base, I think is nothing. I think nothing. Think your grass in your house. How high you are going to leave your grass. Because at the end, the vitreous in the vitreous base enters in the retina. Then you cannot remove it. At the end, you leave a line that may be contracted and to promote retinal detachment. The only thing to relax this is a screwbuckle. Look at this. I'm going to speak of these 4 things. Okay. First, the circling buckle. You have to understand that, when the retina detaches, has been demonstrated many years ago. When retina detaches, it contracts and it decreases the elasticity of the retina. Okay? Let's go here. Oh, that's what happened. Let me show you this guy. Who knows this guy? This guy is Robert Hooke. Was contemporary to Isaac Newton. And they didn't get along too much because they're always fighting and criticizing each other. He described this, have you been in Sagrada Familia in Barcelona? Have you gone to the top? You see these catenarias? He described the catenarias. This guy. Also, he described the law of elasticity. And the law of elasticity says that the force you have to apply an elastic environment depends on the constant, that depends on the tissue, and depends on the change in the length. Right. Let's go to the eye now. Okay, look at this. This is the retina. Let me try not to press it. This is the retina detached. The retina detached, as I told you, has decreased the elasticity, okay? But football, they have membranes, and you are very good surgeons, but to remove all the membranes is so difficult. So difficult. Then, if you want to put this retina here towards the RPE, it's very difficult. Then, if you put a scroll buckle, you reduce the circumference. In the place where is the posterior border of the vitreous base, then you reduce the traction. Okay, look at 3 cases, 3 or cases of mine, okay? The first to the left is a cardiologist. Only one eye. His son, ophthalmologist. Specialty, retina. Then he did a primary vitrectomy. And this is the result. Okay? How many of you would say, of these cases, who needs a retinotomy?
His son.
Let me tell you, no one. Not this, not this, not this. Okay? This is an old, this is a giant retinal tear, not previously operated, long-standing giant retinal tear with PVR. Okay? Let me show you. Let me show you. This is the first. This is the this is the doctor. Okay? Let me check if it works. Okay. I'm going to explain my steps all the time. Then don't try to catch everything at the first. Okay? Then look at the buckle in the posterior border of the vitreous space. Now, all the breaks are supported by the buckle, and you have reduced, the circumference. Then, it's very easy the retina to stay there. This is a primary retinal detachment with PVR. The patient didn't have previous vitrectomy, only laser. And look at the buckle. Then you have to do what you have to do. Now you are going to see it. Look at this. In the membranes, I'm going to explain why. But this patient did not need primary PVR does not need retinectomies in general. Then you put a buckle, you relax the posterior border of the vitreous space. And this is the third giant retinal tear, no previous vitrectomy. Look at this. Look at the buckle. Then the buckle makes that this border may be applied to the buckle. Okay? This is the look at this. You see the buckle. More straight than the buckles of Andrea. Why? Because was so much contraction that I try to really, put a buckle. Look at this is the third. These are the cases. No retinectomy. Because they are primary PVR. Okay? Let's go. Many people say, okay, you can cut the retina. Of course. You make what they call relaxing retinotomy. What does mean relaxing retinotomy? Look at this. If you cut the retina here, in this circumference, and you cut it, the retina is not contracted circumferentially only, also anteroposterior. Then the retina tends to go posterior, right? Or no, go a little. And where is the circle there? It's glitter. Then you are not relaxing the retina. You are putting the retina more stretched. Then you can put breaks. You do 4 rows of laser, and in many cases, works. But always try to leave the retinectomies till the end. And as been published, that if you have a high risk of PVR, it's better to place a buckle. The results are much easier to perform lensectomy, leaving the anterior capsule until the end. At the end, you will decide. The visualization is perfect. The iris does not move. You don't need to put any viscoelastic material in the anterior. This is a PVR case, okay? A typical PVR case. This is lensectomy. The anterior capsule is there. Now I'm polishing the anterior capsule. Look at the iris. It didn't move. Look at the posterior pole. You can see perfect. You don't see the borders of the lens. Never, if you do phacoemulsification, don't put the lens in the beginning. Don't do it, because you will lose part of your visualization in the periphery. You will see the borders of the lens, then don't put it. Even in another case, in diabetics, in complex diabetics, if you are going to perform phacoemulsification, don't put the lens in the beginning, because you are going to lose something. Visualization, okay?
When the cataract is quite hard,
I use a phacoemulsifier. This is a phacoemulsifier for 23 gauge.
you go.
Yes, I open others. Okay. No problem. You will see it, and at the end you decide. Some surgeons, as Stanley Chang, you will have plenty of options. You have now Gore-Tex, you have Carnevale lens, you have Yamane, you have everything. then you don't need to put the lens in the beginning. At the end, the visual result will come in the first week until you remove the silicone. Some patients will find this, and you have to fix this. You have to fix it. Because if you don't fix the third chamber, you won't have good visualization. And in this case, for example, a good thing to do is to open the anterior capsule, intuit it with the individual tip. With some viscoelastic, you can do it. And with this, you will improve visualization. Again, if you don't see perfect, your surgery will be a chaos. 2 days ago, I have a patient with PBR. I didn't look at this. Look at the visualization when I got it, the capsule. You know, it's perfect. Okay, it would be better with only the anterior capsule, but you know, it was not possible. Okay, let's go. Where to begin? You have three main pictures, three membranes. Posterior membranes. Posterior membrane, for me, we digest much more retina than you expect, because the retina is like this. If you eat this, you are eating this. Then it's very difficult, the prognosis is very bad. Okay, let's go with this. Let's go. Typical case, okay? The first thing I do is try to remove as much as possible. I know I'm going to cut the retina. I know it. There is a buckle there. But I know that I have to preserve as much as possible the anterior retina. And I'm going to cut it. And I know it. I'm going to cut it. But I try first this anterior traction that very visible. Then I go to posterior and the cutting. Okay? But the cutting always at the end. When you see where you have to cut and you know where you have to try the main instructions. Look, you have seen it. I always stayed under air. And one surgeon of my team told me once, wait, you make fluid air exchange, and then you stain, and then again to fluid. You are losing time, and you know this is another step. No, it's not another step. Face, very tiny, you will see now. Okay, look at this. Well, typical case of PPR. There's a buckle in place, but you know, detachment and membranes. Oh, the video.
Все одно є наслойка. Тобто бакал ще зроблений чи раніше.
The cases that you have a break in the posterior pole. For PVR, this is the worst thing can happen. Because these membranes are very difficult to remove. And then you have to, let me check where you have to play. Wow. Check. Okay, that's it. Then, the thing we do is fluid exchange. You are not going to reattach the retina, you are removing the fluid under the retinal macular hole also. And this is another maneuver, very interesting. It was described by an Italian guy, Cesare Fumini. It's to stain under perfluorocarbon liquid. Amazing, amazing. I've been using this for more than 15 years. He described the technique. Okay, well, this works. And always try to remove in PVR, always try to remove the interlimited membrane, because this will prevent the epiretinal proliferation in the macular area. If you are not sure, stain again under perfluorocarbon liquid. You stain it. It's very easy to do it. It's very easy. It's very easy, and stain the interlimited membrane very, very, very fast. Look at this. This was the piece of the interlimited membrane that was, leaving over the retina. Look at this case. This is a very interesting case. Just to relax a little bit. This patient was operated in Barcelona by a colleague for a giant retinal tear, temporal giant retinal tear. And he put the buckle. He put the buckle, and doing the laser or whatever, he had a massive subretinal hemorrhage. The visual acuity was light perception only. This was 5 years ago. Look at this. I tried to show you how important it is to remove the ILM. Look at this. This is what came to me, mastectomy. Look at the iris. I don't care. It's light perception. Be careful. Then, I had to detach the retina and to remove the blood. This in the video is so nice. So I say, but when you do this, you're dead because blood begins to go to the vitreous cavity, and then you don't see anything. You see a white thing. This is the retina moving like this. Like you are afraid to eat the retina with. Yeah, sure.
Did you use PPA?
Yes, I inject PPA. Yes, yes. And the same day, the same moment. Sure. The same moment. Yeah.
39Z, 41Z.
41. Then look at this. In the first surgery, I remove all the blood and I remove the internal limiting membrane. But remember, it's a case with a subretinal hemorrhage, complex retinal tear, has all the problems that go to the PVR. Okay. Okay, look at this. This was 3 weeks later. Let's go. Look at this PVR. But look at the macula. There are no membranes in the macular area. The membrane is there. Why? Because you peeled before. Again, fluid exchange. Stay in the membranes. Look at the membranes, blue. They say, please, remove me. Yeah, sometimes I see it. Okay, then, very careful, from down to up, you remove these membranes. Visual acuity at the end? Yes?
What's the same?
Hmm?
What's the same? What's the same?
Light perception?
Yeah.
6 months later, this is 2 years later. Vision is 2040. No, 2040. Maya, because I show the micro cases. Of course. I show you one bad case, but only one. Okay, so let's continue. Why I build the membranes under the fluorocarbon liquids? Perfluorocarbon liquids were described by Stanley Chang many years ago, and they described it for giant retinal tears, to reattach retinal tears. But in '89, we were in a meeting in New York with Jorge Rothschild, and we started to do all our PVR cases under perfluorocarbon liquid. Why? Because it was faster. Because you put perfluorocarbon liquid, at that time we didn't have dyes. But at that time, you and this is the aspect. If I do air, the air go, behind the retina. If I stain, all the dye will be behind the retina, and then will be a mess, total mess. Then the thing you have to do is try to localize and to recognize the blood veins. Notice, because everything is white and it's difficult to do. But when you remove all of these anterior membranes, the retina becomes more relaxed. And then you can use perfluorocarbon. This maneuver, this is using 2 forces. You grab the membrane, you put the other forceps like this, no closing the forceps, then you pull, and then you press the retina down. Okay? It's trying to avoid to put the retina to you. Stay on the perfluorocarbon liquid, just have for reading, and then you remove everything you can. You remove all the retinal membranes you can. This is the aspect here. And 6 months later, Gore-Tex. I didn't use Carnevale because I had to put gas in the eye. I removed the remaining membranes that they formed. It was a heavy silicone oil. And this is the aspect. At the end, visual acuity? Yes. 0.3. No, not that much. Not that much. Intraocular pressure? Low. This is the worst, for me, the worst problem of PVR is not the occurrence of the membranes. Membranes have a life, It arrives one time, the membranes stop. The pressure, the intraocular pressure, the membranes that form, we can discuss this in the ciliary gland. Subretinal membranes, my advice, always remove first the epiretinal membranes. Don't try to remove first the posterior membrane because it's a mess. Then look at this. This is a typical case, PDR, first remove the silicone oil, then fluid exchange that I explained before, fluid exchange and the staining. Look at the membranes, blue, stain, wonderful, and then the perfluorocarbon liquid, you counteract the forces that you're feeling, okay? Look at this is a hard, in fact, we make a video that was my hand with a glove, pressing the retina down, it was a wonderful video. Then I knew that I was to cut the retina, I knew it. But you know, now everything is relaxed, and then you can cut the retina. Always under perfluorocarbon liquid. I will show you, because some surgeons, look at this, we burn the retina, and we are going to remove the subretinal parts, okay? 2 hands, again, very slow, leave some perfluorocarbon liquid, just in case it bleeds a little bit, and then at the end, fluid exchange, and silicone oil at the end. Some surgeons, once I was speaking about PDR, and some surgeons say, no, I'm aspirating and cutting the retina. Suddenly, the anterior retina is attached to the RPE. Then you cannot continue the retinotomy. Then it bleeds. Where goes the blood goes to the macula area. Then this, for me, the best way to do it is to put perfluorocarbon liquid just below where you are going to cut, and then you cut it. Heavy or non-heavy? How many of you have tried to use heavy silicone oil? Okay. How many of you didn't try because you are afraid of you have problems? Nobody. Okay, Mario is an expert in silicone oils in general. Let me tell you one thing. First, the force, you know the concepts of tamponade, you have the force, you know the concept of force of tamponade, then the 2 oils make the same, one superior and the other inferior. From the chemically point of view, the substance that is coupled with silicone oil promotes, it's written in the papers that some papers say no inflammation. In my opinion, it promotes some degree of inflammation. The F6H8, this is part of the composition of the heavy silicone oil. Then, my first advice is always when you have a patient with Densiron, never remove the steroids, the topical steroids. I don't know if you, Mario, agree with me, but I never remove the steroids. Because if you remove the steroids, you will have posterior synechia, very frequent, and more frequent you will have hypotony. Then I always, when you don't have Densiron, in these cases, I never remove the steroids. Well, there are papers, I'm talking about this very late now, there are papers talking about this, but there was this paper that the Stano Rizzo and others, try to know if was, for inferior pathology, lumpectomies, PVR, etc., was better than light silicone oil. And the problem of the paper, the problem of the study was they tried to obtain 700 people, but at the end, in the total group, they obtained only 94% patients. And they describe because they have also inferior membranes with Densiron. And I say, okay, first, we are not so good to remove all membranes. You leave part of the membranes there. Then, these are membranes that perhaps they were there. Okay? Then, they put up, but there are papers now saying that Densiron for inferior pathology with giant retinectomies, is better than non-heavy silicone oil. These are papers saying this. And another thing that many people say is, it's so difficult to remove the heavy silicone oil. So difficult. Maybe I heard this in all the meetings. It's so easy. Why? Because heavy silicone oil always stays down. You begin to aspirate. The only thing you need is to open a 20 gauge spirotomy. So difficult nowadays. 20 gauge sclerotomy, you put, a large, let's say 1.5 millimeters avocad, it's so easy. Non-heavy silicone oil is not that easy because non-heavy silicone oil, when you remove it, is going up behind the iris, behind the lens, and you don't see them. This is one of the reasons why you have many big bubbles of silicone oil in the post-op. Look at this. To remove heavy silicone oil, look at this. Look at the image. The silicone oil is down. It's so easy. You make some siphoning, you go up, and that's some. Some bubbles go down, no problem. You go down with a bit of tip, and you are straight. Look at this. 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 It's so easy to remove heavy silicone oil. So easy. Look at these bubbles. They go down and can be removed. Now the topic of today is methotrexate to prevent PVR. There are many papers. I'm going to comment this because there are so many papers now. There are different regimes to use it. Every 3 weeks, every 2 weeks, every fusion battle. We need more information, but this seems to reduce PVR in certain cases. Very important in trauma cases, but I'm worried about the cases that develop hypotony. It will, methotrexate decrease the ratio of hypotony in this complex case would be a wonderful idea. Then these are my tricks. This is my recommendations. First, think about the scleral buckles. Think about scleral buckles, very important. Second, improve the visualization. Improve visualization means, again, if it's a PVR, you got true PVR, no 2 membranes down. True PVR, remember